The following is a presentation on scapholunate advanced collapse, presented to you by Martin Garcia, Ashley Guerra, Rachel Lindhart, and Brandon Plyler, SPTs at Texas State University. Scapholunate advanced collapse is a pattern of arthritis in which the degenerative changes occur in the same order every time. It can occur after an injury to the scapholunate ligament, after an intra-articular wrist fracture, or as a result of pseudogout. The main problem with all of these different causes is that the scaphoid does not rest within the scaphoid fossa properly, which leads to altered wrist kinematics and eventually causes destruction of the articular cartilage. There are 3 stages of SLAC which delineate the order of progression of SLAC. In stage 1, only the radial styloid portion of the radioscaphoid joint begins to show some degeneration. In stage 2, the entire radioscaphoid joint is affected. Finally, in stage 3, there's degeneration of the articular cartilage of the capitate and the lunate fossa. SLAC is formally diagnosed with a radiograph, but there are some typical exam findings of SLAC. The patient will have decreased range of motion inflection and radial deviation. They will have pain during weight bearing and possible dorsal radial swelling. At the end of passive range of motion, they will have a bony infeel and their pain will be worse at the end range. For SLAC, conservative management just delays surgery and won't be able to correct the damage that has already been done to the joints. Possible options are steroid injections, modalities such as moist heat or paraffin, splinting, and exercises involving flexion and extension movements with bands to prevent excess stiffness. If conservative treatment fails, surgical management is indicated. Here are some of the common surgical procedures for SLAC. Denervation is one surgical option. It can be a complete denervation, which cuts all the nerve branches to the wrist, or a partial denervation, which cuts only the anterior and posterior interosseous nerves. The purpose of this surgery is to eliminate pain without affecting the mobility of the patient. It is indicated for older patients who are mostly sedentary. A long-term follow-up study by Schweizer et al. Showed that 66% of patients had long-term improvement and 50% of patients had complete or marked pain relief. It is not uncommon for patients to experience with weight-bearing activities, and since the surgery does not affect the underlying cause of pain, they may have to have a follow-up surgery to address the degenerative changes. Proximal row carpectomy is one of the 2 most common surgeries used for SLAC. As the name describes, the proximal row of carpal bones are removed, including the scaphoid, lunate, and hamate. It is indicated for patients with stage 1 and stage 2 SLAC, and for older patients who have good mobility and only have to perform light manual labor for daily activities. The surgery is contraindicated if the head of the capitate and lunate surface have large cartilage lesions, if the patient has inflammatory arthritis, or if they are heavy manual laborers. Here are a couple images that show the wrist after a PRC, and you can see the radius and the ulna now articulate with the remaining carpal bones. Four-corner fusion, or FCF, involves the lunate, capitate, triquetrum, and hamate. This surgical procedure is commonly indicated for stages 2 and 3 SLAC and young patients that perform heavy labor. The procedure involves excision of the scaphoid to decrease post-surgical range of motion loss, followed by denuding the articular surfaces of the 4 involved carpal bones. Before fixation by hardware, surfaces are packed with bone graft in order to provide a predictable fusion surface. Fixation methods include the use of K-wires, staples, screws, or dorsal plate. While dorsal plate is the newest of the available methods, current evidence shows that the rates of complication are much higher as compared with traditional approaches. In 2009, Mulford et al. Published a systematic review comparing four-corner fusion and proximal row carpectomy. They analyzed 52 articles with over 2,000 patients and a minimal long-term follow-up of 12 months. The systematic review found no significant difference between the 2 procedures for grip strength, range of motion loss, patient satisfaction, pain relief, or the need for follow-up surgery requiring full wrist fusion. Here we see a graphical representation of outcomes with no significant difference between the 2 surgeries. Grip strengths were both around 75% of the unaffected side. Patient satisfaction was between 80 and 90%. Pain relief was reported by 85% of patients. There was a minimal range of motion loss of approximately 5 degrees with both procedures, and 3 to 4% of patients required a conversion to a full wrist fusion. There were, however, significantly more complications with proximal row carpectomy, even though 11% of four-corner fusion complications are attributed to hardware, which is not a factor associated with the proximal row carpectomy. Additionally, proximal row carpectomy has a significantly higher incidence of post-surgical osteoarthritis. This evidence implies that four-corner fusion is more likely to have positive outcomes, especially if traditional fixation methods are used in order to avoid hardware complications. Full wrist arthrodesis is a total joint fusion. In this surgery, a plate is fixated from the distal radius down to the third metacarpal. This surgery has good outcomes for pain relief, but wrist mobility is sacrificed. It is indicated after failure of another surgery as a salvage procedure or as a primary treatment for young patients performing heavy manual labor with joint stiffness and pain. Better outcomes were reported for this surgery if it was done as a primary treatment instead of as a salvage procedure. Here are a few images of the full wrist arthrodesis. Physical therapy is indicated following surgical repair. During post-op rehabilitation, the physical therapist should communicate effectively and cooperate with the surgeon's protocol. The therapist should be prepared for significant limitations in function, and the therapist should avoid aggressive attempts to regain motion as synovitis and pain may occur. The following post-surgical protocols can be used as guidelines for treatment. The rehabilitation protocol for proximal row carpectomy includes wound care, scar management, and passive range of motion in the first 2 weeks. At 2 to 4 weeks post-op, the therapist should continue finger and elbow range of motion exercises, but should not begin wrist active range of motion exercises. At 4 weeks, wrist active range of motion may begin along with scar mobilization and pain control therapies. Advanced exercise programs, which should include grip strengthening, may begin at the 6-week mark. Post-op rehab for four-corner fusions should initially include wound management at 1 to 2 weeks post-op. Digit and shoulder range of motion and patient education regarding the avoidance of gripping and resistive exercises should be addressed at the 2 to 4 week mark. At 4 to 8 weeks, elbow range of motion should begin for these patients. At 8 to 12 weeks, therapy includes scar mobilization and joint mobilization techniques at the radiocarpal joint. Active range of motion of the wrist can begin once bony consolidation has occurred. At 12 to 16 weeks post-op, and once wrist range of motion has increased, grip strengthening should begin. The physical therapy protocol for a total arthrodesis includes digit, shoulder, and elbow range of motion from the 1st through the 8th week, and a short arm cast is generally applied at the first post-op visit. At 8 to 12 weeks postoperatively, the cast may be removed and converted to a wrist splint. Treatment should include gentle strengthening to digits and elbow, scar mobilization techniques, and grip strengthening exercises once bony consolidation occurs. The clinical bottom line for this condition is that if conservative treatment is not successful for treating SLAC symptoms, surgical management is indicated. Surgery options should be discussed between the surgeon and the patient, and the decision should be made based on the patient's age, functional demands, and residual mobility. Surgery should be followed up with physical therapy that is impairment-based or using the surgeon's protocol. Here are our references. Thank you.